Hi, this is Hemel Gata presenting a amulet left atrial appendage occlusion case that we did recently. I'm joined by my colleague in the case, Dr. Roberto Hodaro, who would be handling the TE imaging. So the Amplatzer amulet is a left atrial appendage occluder that's been out in the commercial market for a couple of years now. The disc at the very end of that device is designed to completely seal the left atrial appendage at its orifice. It's a disc and lobe or disc and hub model. The lobe itself is what provides the radial force to really bind to the appendage. It has stabilizing wires which engage with the wall of the left atrial appendage to help hold the device in place. And then this waist that really maintains this distance and tension between the lobe and disc, and this flexible connection allows the device to self-orient, as we'll hopefully see in our case. The Amulet IDE trial was completed, and that led to commercialization of this device. This is a very busy slide, but in general, about 2,000 patients were randomized in one-to-one fashion between the Amulet and the Watchman device. And you see that it was really non-inferior at all the hard endpoints that were studied with regards to Watchman. So our case is a 70-year-old gentleman with paroxysmal non-valvular atrial fibrillation. He's had a history of supraventricular tachycardia that was status post-ablation. He has an existing iatrogenic ASD that is mid and anterior, as we will see. History of congestive heart failure, hypertension, multiple sclerosis with recurrent urinary tract infections and hematuria. He has stage 3 CKD. He had an acute subdural hematoma back in 2011, but did resume anticoagulation safely from that point. Because of all of this and really his recurrent hematuria that's required hospital stays, he was deemed a suitable candidate with shared decision-making for a left atrial appendage occluder. So here's our baseline TE assessment, marching through at 0 degree, 45 degree, 90 degree, 135 degree. There's a very small wing, both anteriorly and a little bit of a pouching posteriorly as well, as far as this appendage is concerned. There are some proximal trabeculae that we will hope to cover with this particular device and its two components. When we do our measurements, we measure a centimeter from the orifice down into what's called the landing zone for this particular device. And you can see that that measurement is 22 millimeters, 21.5 millimeters, 16 millimeters, and 19 millimeters. And when we look at the way that sizing has worked for this device in the past, we really look at this chart A here. And when we're in that ballpark of 19 to 22 millimeters, as far as our landing zone is concerned, we would be behooved to move forward with a 25 millimeter device. The table below is another analysis that was done using CT data. Clearly, we're using TE data here, so it's not at all pertinent. So really, our only access is going to be the 8.5 French right femoral venous access that we use for the Baylis system. And then we're going to transition that to the 12 French TorqueView 4545 that we're going to be using to deploy the 25 millimeter amulet. We will be using a C1 needle for this case, and we will try to use the iatrogenic ASD and not really buzz across the septum, creating another hole. And we are going to be using a closure with a figure of 8 suture at the completion of the procedure. So let's move on to the case. We did package it together with GHX Explorer Surgical, as you'll see. Thank you.
Okay, great. We'll take the needle. Can we give heparin, please, Ed? Yeah. Thank you. There we go. Okay, perfect. Thank you. All right, going in with the Baylis needle. Thank you. All right, so we'll aim for that iatrogenic ASD from the SBT ablation.
Sit up here. Let me ask you a question. You're doing TEE imaging pre, no CT imaging pre. What about a TE makes you pick one commercially available device versus another?
It's a great question. And so really, I think that the osteal nature of pectinate muscle, clearance to the mitral valve is going to have you pick one versus the other. Those are the two that I really go for. And then, of course, some other dimensions that would be related to the appendage. You know, we're about 60-40 CT-TE at this point. This patient just happened to have a transesophageal echo, but would love your thoughts with regards to CT versus TE in assessing these patients.
Yeah, sure. Okay, good. All right, so we're through that previous ASD now, and then we'll take up our.
I think it's an interesting paradigm with
wire
TEE. The slippery slope
through
is
the
to
bailiff
not
here, and then
obtain
we're
an
going to put in
upfront
our
TEE and
12
to
French
obtain TE on the
torque
table
view
at the
40,
first
40,
image.
45,
And
45
those are the cases where I
sheet to
find it hard to
deliver
pick one
the,
manufacturer versus another, or
amulet.
one device versus another. If you're simply looking at the TE for sizing of the device you've already chosen. And that's
All
why I
right,
think it's
that
helpful to
looks
have
good.
something up front. And
Put
if
in the
that's a
nice LV
non-invasive
there.
study with the CT,
Okay.
if the sizing is set up and equally easy to do on each, I think that's
All right,
a
all set.
valuable thing to have.
Yep.
All right, just pan back to the septum. We'll cross the sheath through it. All right, good. That should be across now.
X-Pen? Yep.
Awesome. Okay, so then let's go ahead and walk the dilator out. And then we'll take that copilot.
X-Pen.
Yeah. And you can just put the copilot on first, sorry. Put it on here. Yeah. Mm-hmm. Good. All right, very good. And then we'll load the pigtail in. Let's go to a fluoro over-the-shoulder view here to open up the ostium of the appendage. So that'll just be like a roughly RAO 20, cranial 20 view. Let me know when you have wire. Got it? Hey, you take wire out. Yep. All right, here's our pig through the mitral valve. We're not doing that today. All right, so that in the appendage?
Yep. Sure.
Wonderful. So we'll just walk our sheath right over there. So we typically don't do much in the way of contrast injection here, but we will for this procedure. Yep, I'll take contrast. And then we'll also take an ACT syringe. ACT syringe. And give me like 20, yeah, 20 full strength. Yeah, that'll be fine. Yep, and that little recess, yeah. That would be great.
Hemel, I see that your imager there went to an X-plane modality, and I think that's really helpful. This is another one of those areas where our interventionalists and our EP docs who may not pick up a TE probe in their life know this view and
Here's
like this
our
view. So it's
EPP.
always interesting when they say, you know, give me the X-plane.
All right, we'll do a contrast right
Absolutely critical.
Nice. All right, so it definitely lays out the ostium of the appendage quite well in this areocranial view. The thing that we lack, obviously, is discrimination anterior, posterior. So we know that there's like an anterior wing component to this. But what we can make out really very nicely here is the ostium of the appendage coming down to the contour of the left atrium. So this is a pretty good view. So we've already examined our TE parameters as we already walked through, and we're going to pick a 25 millimeter device to deploy here. So we'll go ahead and take this all out.
Hemel, when you went into this,
Pigtail and the
did you
co-pilot
plan
come out, and
for
what
a
we'll do is
sandwich
just kind
approach
of,
up
what's your-
front
what
or
connection?
either way?
I think either way. I mean, I think that the great thing about this particular device is
you can stop looking.
you don't quite know how
And then
it's
what
going to
we do is
interact
we
with the
bleed back
anatomy
from the
until you
back to
get
it
there,
here.
but there's a lot of flexibility, as you'll see. So as we go to kind of the three components of deployment here, you'll see the immense flexibility that you have with this particular device and navigating within the appendage, and then just defining where you're going to actually deploy the lobe versus the disc. So we'll go through that in just a moment. There's a de-airing mechanism that's very important here with this device. Not so much with Watchman Flex, but with this, we do let the device kind of bleed back a little bit before going ahead and inserting. And then we do a slow flush as we insert the device in through the sheath.
So we're coming up to the distal edge of the sheath right there. Good place to pause. Excellent. We could stop flushing and take the syringe off. I'll center the fluoroscopic image here just for clarity, but we're in a good place here to unsheath the ball. So that's what we're going to do here. So I'm just going to go ahead and just slowly unsheath. Push this forward just a touch, and now this is going to be our ball right here. And this allows us to rotate. So you can see here that we're kind of outside the appendage a little bit, but hopefully just by counterclocking this thing, I get it to sit a little bit more into the appendage. And if I need to, I can just back this up just a touch. There it is, nice and free there. And you can see I've got like plenty of depth here to work with. So now I'm really nicely in the body of the appendage. And what we're looking for here is basically where we want to go anterior, posterior, and be able to torque this thing. Now you can see that there's kind of like a blunt end to this, a blunt end. So we don't really want to lean forward on the device at this point. And so in order to create that safety profile, I'm going to push out to triangle here. And so now that flattens the distal part of the device, and now I'm free to move the device in if I want to. And I will a little bit because I kind of want to anchor it right up against that pectinate. So right here. And then what I'm going to do is I'm going to push out to low. And that's lobe right there. So you can see that the device is nice and deformed here, actually, the lobe is. What I want to do is just maintain half of my device, at least half of my device, below the left circumflex. So Roberto, try to get the circ in view.
So you see it right there in long axis.
Very nice, yeah. So you can see that like about 70, 80% of my device is below the left circ right now. Let's go back to a 45-degree view where we can clearly see the ostium a little bit more. Yeah, and you see the circumflex really nicely there, and I'm really tucked in very nicely below the circumflex. And so the lobe is in decent position here. And so now what I'm going to do is I'm going to unsheath that disc. And you can see, again, the lobe is nicely deformed, so we'll pay attention to that. But I'm just going to go ahead and unsheath the disc of the device here. And really, we want that to lay right over the cuminid ridge like that. And we get decent separation between the lobe and the disc here, which is one of our criteria that we're going to use to assess this device. So the device itself and placement looks good. We're well past the circumflex with the lobe. The disc is covering the ostium very nicely and completely. And so now what I'm going to do is a tug test by basically pulling on the disc of the device, creating like a football shape, and seeing if anything happens with the lobe. And I just basically hold here for about 5 seconds. And you can see here that the lobe is nice and stable and really anchored very nicely in the appendage. And so I'll go ahead and let that go right down to that. And then Roberto, why don't you just do a TE assessment here, and we'll give a little bit more contrast actually, just to look, but yeah, we'll take another 20, yeah.
Sure, we can put color here.
Yeah, Roberto, just talk through what you are.
Yeah, right now we're just putting color. It's important to drop the color scale to 35 or 38 to make sure we detect any low velocity flows, and this looks well sealed. We see pulmonary flow there, but not flow through the device or through the, and we'll do that in all angles. So we go 0, 45. Again, it looks here that there is no flow through the device, per device flow. 90 degrees. Device looks well positioned, as we said, below the circumflex, and then 135. So this looks like a good position. I don't see any evidence of device flow here.
Excellent. All right, so just for instructional purposes, we'll take another contrast shot here. In that same over-the-shoulder fluoroscopic view, again, we'll be able to see like the true ostium of the appendage. And the great thing about this device is that that disc is really going to hug the ostium with no protrusion into the left atrium, as you see right there. So really just complete coverage of the ostium of the LAA. You can see the nice separation between the lobe and the disc, and this looks really good. So we'll go for release. Now, the release here is very akin to ASD PFO devices made by Abbott. And so basically what we're going to do is just counterclock the cord that is basically attaching the device right now, just counterclocking, and that's it. Roberto, why don't you take another look?
Sure. Let's put color here again.
I'll take the figure of 8.
And we're gonna go again on this view. And again, this is a very critical view, the 135 view. And I think there is some gutter flow there, but there's no flow through the device, as you can see on this view. I don't see any flow getting inside the appendage there. We can also do a color off, and we can do a 3D view here. So we can do an assessment on 3D.
Can we get 50 of protamine, please? Thank you.
Good. And we can put color here again. It looks very good here on this one. Very good. And we look at the intraocular septum. We went through the previous.
So Hemel, your
iatrogenic
morphology
ASD.
worked
We'll
out
make
really
sure
well
there's no
for
change
amulet here
Color.
with the wing.
And Roberto, after you do
What's
that, just
what's
show
your
the relationship
anticoagulation
between
plan?
the
You've got a
mitral
really good
annulus
seal here.
and the disc.
Is this a DAPT
Yeah.
patient? Is this
And
a
that looks good.
DOAC patient?
So
What are you
another,
planning?
kind of
For us,
nuance
this
with
would be
device,
DAPT
given the disc,
for
is that
a
we do
month,
respect,
for
the left upper
for about a
pulmonary
month
vein,
actually.
as well
What about
as
for
the
you?
mitral annulus.
What would you be doing?
And we definitely don't want the disc to interact in any meaningful way.
I think a
with
lot of
those particular
times
structures. And you
just
can see
depends
here
on
that
what
we're
they may have come
offset
in on. If
from
they've
the
been
mitral valve
tolerating
insertion
a
quite nicely.
DOAC before
Really
this,
not impairing any
I'll
kind of,
continue it
mitral
for the
valve
6 weeks
function.
or 2 months until
Yeah,
the
and the mitral
TEs,
valve
the
had
follow-up
trivial
TE is
MR,
done.
and there's
If they've been
no
on
trivial
nothing
MR,
because
no-
it's been
no change.
prohibitive,
All right, perfect. And then
I've
the other
also
thing,
been
obviously,
doing
we test
that.
for, given the clinical trial data, is the presence of a pericardial effusion. And we typically do get transthoracic echoes routinely on these patients later on in the day, but as you see here, there's no evidence of effusion after the deployment.
and are
we'll
you
do that
sending these
transgastric
patients
use
home the
as well.
same day?
No. So let me just, yep, I think we're done with that. So yeah, I think that the whole thing about this particular patient population right now is it is still coded, underneath an inpatient DRG. So we are still keeping these folks overnight. I think that in the COVID era or the peak of it, we were putting that little that little note in the chart indicating that in the COVID era, we are trying to move these patients out quicker just for bed capacity issues and whatnot. But right now, we are keeping these folks overnight. We have a couple of minutes for discussion here. So Sandeep, Dustin, Matt, Amber, any comments about the device selection here, the deployment, and kind of your insights onto left atrial appendage occlusion in general?
I mean, I'll just start. You had a great result. Back to Dustin's original point of how do you choose up front. I think ideally down the road, this should be the type of thing that we can choose on the fly. Because I've at least gone away from routine CT because I don't think the measurements are helping me much. I'm relying on the TE more and more on my angiogram if I need it. And I think 90%, 95%, we can treat with either device. We just need to decide over time which one is going to serve us better. One question I'll leave with for you, though, is how often have you run into any issues with the disc and the mitral apparatus? So it's always there in theory. We're almost never looking at that number. We're sizing everything on the lobe. I've never seen it where it's gotten too big, but at least in theory, we start discussing it. Have you had that problem?
Yeah, I guess I try to screen those out, right? And so because we have both devices and we're kind of a splitter account, those are the devices those are the cases where we are getting the pre-imaging up front. And on CT and TE, I can be pretty kind of methodical about understanding what my clearance is. And so if it's not like 5 millimeters, then I definitely pause. And there are some minority of cases where I can just do a measurement quick from that inferior border of the appendage down to the mitral valve annulus. And if it's ringing up 5-7 millimeters, I kind of shy away from an amulet in those cases. But I personally have not seen any disc interaction with the mitral valve.
So as somebody relatively new in the space, let me ask this question. Going back to my pre-procedure planning with imaging, if it's not an imaging criteria that you're looking for, and you have a very broad size range, and the success rates in the trials as are they are, what is not a flex case, right? I mean, why do we
Yeah.
need a second device? What is not a
Yeah.
candidate for the first device?
I'd say broadly speaking, so what I do look for now in a little bit more nuanced way is osteopectinate, right? So complexity that's more proximal in the left atrial appendage contour, that's going to shy me away from flex because I'll either end up with a large shoulder or I won't cover something, or in some cases, both. And I think you'll be surprised how many anatomies, if you do pre-screen, you'll find like that. And those definitely swim you towards Amulet.
I think the other case, large funnel-shaped appendages where you're going to end up probably placing a Watchman device deep, and then you worry about these caked-on DRTs. We've had a couple where they were failed on Watchman 2.5 that you could come back and very smoothly do an Amulet.
Yeah, and I think the procedural planning here is key. And so, understanding that measurement that you would make kind of interprocedurally, a centimeter down, choosing the right device size, which obviously gain with experience. I think this is as efficient as a flex procedure, most of the time. And I haven't encountered any inefficiencies because of bringing Amulet in to be a sizable percentage of our left atrial appendage occlusions.
Hamel, last year when I had spent some time with you, you were starting to incorporate intracardiac echo into
Yep.
Watchman placement. Do you feel like there's a future for that with Amulet, or is it too nuanced for that?
No, I think that there's a future there also, Amber. I think that right now, obviously it's just economically prohibitive for us to be throwing it out there for every single case. Our shop runs pretty efficiently with the TEE algorithm that we've employed, or utilization of TEE. Like we're able to, crank out 7 cases and be done usually by about 2:30, 3 o'clock in the one room. And so, I think the procedural planning up front matters. Having a really great team to turn over the room matters. But I do see ICE as being, obviously a future component that we'd like to employ. It's just economically prohibitive right now, given the margins that we have on this device.
I thought
Excellent.
I thought that the way that the disc sat in that case was really, really nice. And sometimes we haven't quite achieved that. We have this kind of radar dish type look. And I'd like to think that probably the effort you took at the beginning of the case to really tuck your ball underneath that pectinate, really get a deep,
Yeah.
you make sure you had, what you estimated, I think 78% of your device, the cake part of the device below the circumflex made a difference. And it sat really beautifully. I was wondering how it was going to do with the mitral annulus when the disc came out, but it looked good.
You just summarized the entire procedure, Matt. And that's really it. It's just really getting that ball to sit right where you want the lobe to end up. And then hopefully you don't get that kind of recoil out. And if you do, trying to position the ball in a different place. And that's kind of the nuance that it takes to deploy this device, I think, effectively. But we'll close this component of our symposium. Just a couple-minute break here, and then go on to the most intriguing section, heart valve disease. What does the future look like? So thanks again. Appreciate it.